number of commercial entities. The objectives of the talk are relatively simple. If you've joined, I hope you'll see that we're reviewing the pivotal data on single inhaler triple therapy, and in particular, the combination of indacaterol, mometasone, and glycopyrronium. I want to review the outcomes that one might expect, not only in clinical trials, but in clinical practice. This is built around a very simple case discussion. It's one that is applicable certainly in Canada, and I think given the globalization of our approach to obstructive lung disease, it would probably resonate as well in India. So let me introduce the problem patient. This would be typical of a patient sent to me at the Asthma and Airways Center. This is a 38-year-old woman. She is busy with her career. By the way, no obvious occupational exposures. And she's referred by her primary care physician for her poorly controlled asthma. If you use the ACT, the asthma control test, of course, we look for a score above 20. Hers is just 13. The ACQ-7 is 3.2. We look for scores below 1.5. Amongst many other signs of poorly controlled asthma, she's awakening frequently, and apparently she is meant to be controlled with MART, maintenance and reliever therapy. So she is asked to use budesonide formoterol twice a day, but in what I think is a dreadfully confusing set of instructions to use the same inhaler when it's needed. So 2 sets of directions for 1 inhaler. I think that is a recipe for failure, and it certainly has been for her. Relevant to today's talk, I'll point out that this ancient maintenance therapy of budesonide formoterol is intended for use twice daily, and I think that is a problem in the 21st century. I think there is little excuse to ask patients with a chronic disease to use a maintenance therapy that must be used more than once per day. And of course, that plays into the data we're about to examine. Now, as well as the poor day-to-day control, our patient has had exacerbations. She has gone to a walk-in clinic and received prednisone. And of course, she's been to an emergency room, also received prednisone. And we're beginning to understand that the impact, that is the adverse effect of that prednisone, is cumulative over a lifetime. It's not safe, even though it may be a 5-day course or a 7-day course. This is having its effect on her risk of cataracts, bone density loss, cardiovascular, cerebrovascular disease, and so on. The history is fairly typical. She had some childhood allergies, and the remnant of that in Ontario, where I practice, would be in the fall, in the autumn, some allergic rhinitis. She did get an inhaler when she was a child, but as is often the case, no clear diagnosis of asthma was made, although that seems likely. In terms of adult symptoms, they began 5 years ago. There are no pets in the household, a little bit of a smoking history when she was in university, but nothing relevant to today's scenario. I'm speaking to a pulmonary audience, so here we have it. I'm sure everybody glanced at the flow volume loop on the right, so we can see an obvious bronchodilator response obstruction that is persisting even after bronchodilator. For the physical examination, some swollen nasal mucosa, and there are some wheezes heard in the chest, but I think the important information is on the right-hand side of this slide. Up at the top, exhaled nitric oxide. I don't know how readily available it is in your practice. I use it. It is not reimbursed, so I use it judiciously in my practice, but obviously that is an elevated exhaled nitric oxide value, and it would make you think of many possible things. Certainly type 2 airways inflammation that is unchecked. Is it possible that she's not using or unable to use her inhaled corticosteroid therapy, because nitric oxide usually plummets when patients use inhaled corticosteroids? The blood eosinophil count's a bit elevated, so is the IgE level, and as you can see, the allergy skin tests are positive to a number of common aeroallergens. very important, and I'll come back to this, we verify that if she is handed an inhaler, she can demonstrate good inhaler technique. So the medicine that's been prescribed should be reaching the lower airway, a very small but fundamentally important thing to be aware of. So let me just ask, and don't dash off to the Cyclamed website for polling. We haven't set this up to be polling, but what would you do with this patient in your practice? And certainly there are some options here. She could be switched from this questionable maintenance and reliever therapy to a once daily ICS LABA. One could move to triple therapy, and we'll talk a bit about this. We could add the tiotropium in its soft mist inhaler format to what she's currently taking. We could look at biologic therapies, and I'm not sure what's available in your practice, but mobolizumab, mepolizumab, benralizumab, one of the mAbs, we could order a test. And I'll tell you that we did sort of a test. It's not a physiologic test. We simply requested her pharmacy records, and we discovered that she's received only 3 budesonide formoterol inhalers from the pharmacy in the last 12 months. She has not been convinced of the efficacy of this therapy. She may not have a drug plan. And so this poor use of maintenance therapy, this underuse of inhaled corticosteroids certainly explains that elevated nitric oxide value and the poor control that we saw earlier. Forgive me for this. This is a Canadian diagram that would be very familiar to the Canadian pulmonary audience, but it does outline some basics. And I'm going to look at the big colored algorithm that's outlined there in this triangular shape. And as you can see, everybody with asthma is meant to have a diagnosis confirmed. We've done that for our patient with that flow volume loop. We want to assess the environment. We want to educate the patient. And patients will use some sort of reliever. I prefer salbutamol. It's uncomplicated. It's safe. But when it comes to persistent symptoms, we follow this triangular strategy. So at the base, mostly in yellow, is inhaled corticosteroid, a second-line leukotriene receptor antagonist. I'm not a fan. I rarely, if ever, use them. We could add to the inhaled steroid because, as you see, the line flattens out. The inhaled corticosteroids run out of steam at some point. We might add second agents, LABA. At the time this diagram was made, the next add-on would be an anticholinergic, and it was specifically, again, when the diagram was made, tiotropium, but now we have several long-acting antimuscarinics that could fill that role. And up at the top triangle, severe asthma receives systemic therapy. In the acute situation, a corticosteroid, and in the long-term situation, a biologic therapy. That's straightforward. I'll point out that in this transition where inhaled corticosteroids are often increased, the addition of a long-acting antimuscarinic may allow us to avoid increased inhaled corticosteroid use. And this is an active question right now in clinical trials. But I wanted to go over here. We are meant to regularly reassess these things, and we have done that. We have looked at control, we've counted up exacerbations, we've done spirometry, we've checked inhaler technique, we've addressed the issues of triggers, we've talked about her allergic rhinitis. Sputum eosinophils are rarely available outside a research context, and very, very important would be this issue of adherence. How do we improve adherence? And I think this is fundamental to this talk, although the focus is triple therapy. Let's talk about once daily versus twice daily. And here's a very simple little study. It looks at the patients who are able to take more than 75% of their prescribed maintenance therapy. It's far more likely with a once daily inhaled corticosteroid than with a twice daily inhaled corticosteroid. I think that's fundamental. I, again, don't think there's a good role left for twice daily maintenance therapies in the management of asthma in the 21st century. But what about this business of a second additional controller added to inhaled corticosteroids? And we go back to a study published by Hugh Kirsten and colleagues in the New England Journal of Medicine. It's actually 2 studies, the tiotropium in asthma 1 and 2. And what I'm showing you on the left-hand side is the spirometric response in tiotropium in asthma 2. So we have across the x-axis 3 hours. We have 2 flow volume loops, or rather 2 spirometric responses. We have LABA ICS. This would have been salmeterol fluticasone. We see an improvement in FEV1 above baseline. But if the inhalation included the anticholinergic, we see a greater response. It was 154 ml. And we note that in the companion study that was identical, the difference was 86 ml. So great. As pulmonary doctors who like spirometry, we could see the spirometric advantage of the added bronchodilator. The question is, of course, does that make a difference clinically? And the answer is yes. Following up these patients over the course of a year, Kirsten and colleagues found that patients taking the additional anticholinergic bronchodilator had fewer severe exacerbations, as described in the study. So we have spirometric improvement, a clinical outcome that's improved, and so it would seem reasonable to add in an external anticholinergic. But we should talk about now applying this strategy in the real world. Should we be doing this? And I'm going to draw your attention to what I think is a clever, very important paper that needs to be quoted more often. Averill and colleagues looked at a health maintenance organization in the US, found almost 2,000 patients taking salmeterol fluticasone, ICS-LABA, not well controlled, who then received this additional inhaler, this tiotropium inhaler, to add to their treatment regimen. The first thing they discovered looking at their data was that 16% of the patients immediately switched away from their ICS-LABA to use tiotropium monotherapy. Well, we hope that's not what the prescriber intended, but clearly there's an educational need here, either a patient or a physician educational need. But then you'd say, well, wait a minute, 84% of the patients then did, I suppose, receive triple therapy, and that's true. However, what about those 84% of patients who still had their salmeterol fluticasone and now had tiotropium? Let's look at the next 6 months, and it turns out over the next 6 months, half of those patients discontinued their ICS-LABA and switched to tiotropium monotherapy. Asking patients to juggle an open triple, 2 different inhalers for maintenance therapy, is likely to lead to this sort of non-adherence. It's not what we want to happen. So, second pronouncement, we're aiming for once daily, and we're aiming to close that triple to make it a single inhaler triple, because open triples lead to this sort of non-adherence problem. This brings us to the development of one of the available, best studied of the triple therapies. This is the development of indacaterol, mometasone, and in triple form, glycopyrronium. I'll say very briefly a little bit about this combination of ICS-LABA, but the focus will be on the triple therapy. This was the Platinum Development Program. It was mentioned earlier. I've been a part of this, so I'm very familiar with the data, and I'm just going to give you the highlights here. Just in case there's some confusion lately, as I present the data, we will be talking about mometasone doses. Mometasone has a great therapeutic index. It was first introduced as an inhaled steroid monotherapy by Merck, generally available in North America, at least in a twist-tailor formulation, and low, medium, and high doses are given here, 200, 400, 800. When we talk about in combination with mometasone, the force agents, the delivery system tells us that, in fact, 80 micrograms delivered in this formulation is equivalent to 200 in the old formulation. As you can see, 160 equivalent to 400, 320 equivalent to 800. And when we get to triple, this nominal dosage coming out of the inhaler, 160 micrograms, is actually equal to 800 micrograms of the original inhaled mometasone monotherapy. So in case there's some confusion, if the numbers don't seem to line up, It's this greater deposition in this delivery system. So I'll just start very briefly. Indacaterol, mometasone, it is a widely available formulation. And what you're looking at is FEV1. You're looking at it at the end of a 1-year trial. We're looking at medium dose or high dose combination. We're looking at the combination of ICS-LABA or just ICS, and we can see that FEV1, unsurprisingly, is dramatically better with the ICS-LABA than simply the ICS component. That's at medium dose, and of course also at high dose. One of the other interesting and I think important things about this development program is it included an external comparator, salmeterol fluticasone, so worldwide trade name Seretide. I believe that's the name used in India, Advair, by the way, in North America. And we can see that this new once daily ICS-LABA has greater impact on FEV1 than the older twice daily salmeterol fluticasone. And just by the by, as well as all of those significant lung function differences, we can also see evening peak flow as measured by patients, always better with the newer once daily combination than the older twice daily combination or the inhaled steroid monotherapy. And in terms of exacerbations, it is, as you would expect, exacerbation tendency is lower, the rate of exacerbations lower with the new formulation once daily versus the old formulation twice daily. That's true whether you're categorizing these things as moderate and severe exacerbations, severe, all exacerbations. The data on the right pertains to the higher dose of indacaterol mometasone, and there the differences are quite consistent no matter how you catalog the exacerbation severity. And now to triple therapy. This is with the addition of glycopyrronium, once daily, long-acting antimuscarinic. And the key study in this is the Iridium study. We're looking at medium and high-dose triple therapy, medium and high-dose ICS-LABA therapy, so the internal comparison. In other words, what does the anticholinergic add? And then, as mentioned before, this external comparator. And just to point out, these were patients who all had exacerbations prior to recruitment. They all had these elevated ACQ scores. They had symptom burden. Look at the dreadful FEV1, that's the average. These were patients who were at GINA step 4 and 5, if you catalog things that way. Here, again, we see very dramatically the lung function benefit of the triple therapy. So here we have peak flow measured in the evening by patients. We have it throughout the 1-year Iridium trial. There is a benefit that is a slight increase above baseline using old-fashioned twice daily salmeterol fluticasone. If we simply switch to the once daily, very potent indacaterol mometasone, we see a greater evening peak flow benefit. But of course, the highest peak flow achievement is in the patients who received once daily triple therapy. What does that mean overall, whether it's morning or evening peak flow? Again, these better results with the triple therapy versus the external comparator, triple therapy versus the external comparator. It sustained throughout the year. It means that we are likely to see fewer exacerbations. And so here we have triple therapy exacerbation rate, dual therapy twice daily exacerbation rate. This is a catalog of moderate and severe exacerbations, the way the data is usually presented. 36% lower exacerbation rate with once daily triple therapy, single inhaler, versus old twice daily ICS-LABA. That's true of severe exacerbations, true of all exacerbations, mild, moderate, severe. So this agent, this combination, a very simple set of instructions for patients to follow, 1 inhalation per day, produces not only the lung function benefit we might expect, but also quite consistently, and versus a very robust comparator, a clinically important outcome. Delivering the medication, the studies were done, of course, with the breezhaler, and this is what the breezhaler looked like in the study. And I love this animation that was put together by colleagues from South America. As you can see, the see-through capsule containing medication nested in the obvious place within the breezhaler. The mouthpiece snapped back into place, the buttons pressed, so the capsule is now pierced. In Spanish, the inhalation. And we can see, and the patient can see, that if the job is done correctly, the capsule is now empty. The medication has been inhaled into the lower airway. I like the next part because it shows, excuse me, what's actually happening here with the inhaler. During inhalation, the capsule actually rises and spins like a helicopter blade. It makes a very distinctive sound that patients can be trained to listen for. And that can be one helpful role in teaching patients correct inhaler technique. This is a slide looking at the low resistance characteristics of the breezhaler. This is the old-fashioned capsule handyhaler that was used to deliver tiotropium for many years. The peak inspiratory flow rate achieved at a standard effort 49 liters per minute in this particular study. Here's the newer Ellipta. It is a lower resistance. It allows for a higher inspiratory flow rate. The lowest resistance device here, and I think the lowest device available internationally for drug delivery, except perhaps for the soft mist inhaler, would be the breezhaler, and we see the highest peak inspiratory flow rate. And a slide that is stolen from the COPD setting. Monomar and colleagues had a look at patients with COPD using various devices in Europe. They looked at the frequency of not just errors, but critical or so-called fatal errors, meaning no drug is likely to be delivered, very high with the high-tech soft mist inhaler. PMDIs notoriously difficult to handle. Turbuhailers, handyhalers, discus, lowest critical error rate was with the breezhaler delivery system. I've often described this as an intuitive system. Patients understand how it's supposed to be used. And with that, by the way, fewer critical errors in COPD. They also saw lowest rate of exacerbations in patients using this intuitive device. So back to our patient, I'll wrap up. She is switched to once daily triple therapy. Very quickly, we see the control score improved dramatically above 20. It's 23 out of 25. She stops awakening at night, seldom uses the little blue inhaler, and not surprisingly, with that excellent day-to-day control, we see with that a lack of exacerbations over the 6-month follow-up. So a very quick summary: adherence. I think one of the very important, and if you will allow me to say the word generic, lessons from this talk: adherence. It is so critical in asthma, and we can do something about it by shifting as many patients as possible to once daily therapy, and by delivering our maintenance therapy in a single device, not an open device. You'll recall that our patient was on this so-called maintenance and reliever therapy. I think it's a travesty. Playing catch up with symptoms is not the way to control asthma. I can't think of any other setting in medicine where we would choose to play catch up. Prevention is the way to go. And I think the once daily indacaterol glycopyrronium mometasone is more effective than much of what we are using, including, for example, the twice daily salmeterol fluticasone used as comparator in the Platinum series of studies. Triple therapy, there's a great role for it in our asthma management. It should be closed, one inhaler, and it should be once daily. And with that, I'll stop and leave room for our next presenter.
Thank you very much, Dr. Chapman. That was a great summary of the triple therapy, especially what you really suggested in a single inhaler rather than giving them separately. I think that was a strong message, equally on the once daily part. And I'm going to then move to Dr. Lance Pinto to present his case. And So, Dr. Pinto, please go ahead.
Thank you, Jaideep. Thank you for that generous introduction. And it'll be a tough act to follow, Dr. Chapman. That was a very comprehensive overview on the use of triple therapy in asthma. I think I'm going to share what most of us as pulmonologists, for most of us, would be a bread and butter case, something that we see on a daily basis. I think one of the things that's unique to the practice of airway diseases as a pulmonologist in India is that this clear demarcation of asthma and COPD sometimes is not that straightforward. Maybe the air pollution has something to do with it. Diesel exhaust fumes, for example, have been associated with eosinophilic inflammation. So it's not as easy as a person who smokes gets COPD and a person who, and hopefully we shall talk about our treatment options based on that. Are my slides visible?
Yes, Lance, we can see them.
Okay. So let's start with a fictitious name, of course, Mr. Raj Yogi. He's a 67-year-old male, never smoker, and had a retired desk job. So his occupation did not contribute or did not have any occupational exposures of note. He is diabetic, he's hypertensive, and has had an angioplasty about 5 years back. So there are cardiac comorbidities, which are commonly seen in patients with airways diseases at this age. Progressive shortness of breath over the past 10 years. So it did not begin early in life. It began somewhere in his 50s. Presently, MMRC 3/4, so quite breathless on day-to-day activities to some extent. Occasional nocturnal symptoms. He had a CAT score of 24, most of it being driven by his symptoms of breathlessness, a bit of mucus production, and difficulty carrying out day-to-day activities. He had no hospitalizations for respiratory symptoms in the recent past. However, had 2 courses of antibiotics over the past year for a chest infection. So I think this is another feature that we routinely face where exacerbations don't get clearly defined. Our patients will give us surrogates for exacerbations, sometimes just going to the pharmacy and picking up antibiotics, sometimes seeing their general practitioner. So it's not that easy to tease out what an exacerbation is. He had symptoms consistent with chronic bronchitis, so did produce a lot of mucus on a significant number of days every year. He gave no history of allergic rhinitis or atopy. There was no family history of asthma. So the conventional things that drive us towards thinking that this is possibly atopy-mediated or type 2 inflammation didn't seem to exist upfront. There was a history of a pneumonia 10 years back. He said he was hospitalized for the same for a week, but recovered quite well from them. Occasionally complained of reflux symptoms. He was also obese, which possibly contributed to his breathlessness to some extent. So when I clinically saw him, he had a prolonged expiration. There was no obvious wheeze when I saw him. There were a few basal coarse crackles, made me wonder whether there was some bronchiectasis. There was a history of a pneumonia in the past, whether that had left him with some scars. There was no obvious clubbing. And he was tachypnic post a 6-minute walk test, even though he didn't drop his saturations. His blood work was really unremarkable, had an absolute eosinophil count of about 172 cells per cubic millimeter. And this was what his lung function looked like. So if you see the ratio was 51. So if you go by the fixed ratio, this was clearly an obstructive pattern. With an FEV1 predicted of about 62% for his age. There was no significant response post-bronchodilator. And if you look at the flow volume loop, this is a typical scooped out loop that we see in airflow obstruction. His diffusion capacity was about 78%, so very close to normal. And when we looked at his lung volumes, his total lung capacity was 123% with the residual volume to total lung capacity elevated. Not over 120%, but about 111%, which suggested again some air trapping. So let's quickly summarize what we've seen so far. So this is an elderly gentleman, not had a lifelong history of breathlessness, a short 10-year history which started in his 50s. Not somebody who smoked, no obvious atopic features. Had a history of a pneumonia 10 years back, has some symptoms consistent with chronic bronchitis, and he presents to you for the first time. So what would be the initial choice of treatment? I think we're going to do a poll at this point.
Yeah, I think there will be a poll at this point, and most people should vote on the CiplaMed app or online, as they're seeing on the CiplaMed app. Not so sure to be able to pick it up.
So I don't see the results. Okay, Jaideep, could you summarize the results because I can't see it? Okay, it's being polled presently.
Can you see them now? Yeah.
Yeah, I'm just trying to figure out how to maximize it.
Well, yeah, about 60% have voted for the triple.
Okay.
20% have voted for LABA-LAMA, 6.7% for monotherapy, and the last 15% is triple along with azithromycin prophylaxis.
Okay, so that's interesting. So I guess the thought process was to some people was triple therapy upfront. Not sure why the use of ICS was preferred in this case, but let's move on to the next question before going to the discussion. So, assuming that you chose to use ICS or you didn't choose to use ICS in this patient, what would be the most important concern when you make that decision? So is it the fact that the person has had a pneumonia in the past? Eosinophil counts are not high enough to warrant an ICS. The person may not be a frequent exacerbator by the strictest definition. You would wonder whether this person could have tuberculosis, producing sputum for some time. We are in India, which is endemic. And the lung function is not too bad, according to you, to warrant an ICS. So which of these five would be the top? I mean, there could be multiple answers to this, but what would be a big concern when you decide to use or not to use an ICS?
Yes, you can see the slide.
I can't see the percentages, but I see the numbers.
Okay.
So is there a way where
right.
I just magnify it? Because I can see it in a really small window.
So I can see that if you want. I can just 40% talked about a past history of pneumonia, 40% that eosinophil levels are not at high, and 20% possibility of tuberculosis.
Right. So I think the past history of pneumonia seems to be a big concern, and we know that the use of ICS is associated with an increased risk of a pneumonia. So I think that's a very fair point. 40% do think that the eosinophils are not high enough. And let's look at, so assuming that our diagnosis here is COPD, because this individual does not meet atopic, does not really have any atopic features, is presenting for the first time in their 50s, is not a smoker, but maybe there are other risk factors that have contributed. If you assume that the diagnosis here is COPD because there's no clear indication to call this person having asthma, the gold guidelines would suggest that this person who is very breathless and therefore fits on the right side of your grid, MMRC is greater than 2, CAT score is greater than 10. The choice of whether you start off with a LABA-LAMA, I guess both the criteria, whether you choose a frequent exacerbator or an infrequent exacerbator, they definitely would deserve dual bronchodilators by virtue of having 2 exacerbations in the past year. The choice of an ICS based on the gold guidelines would be based on whether the eosinophil count is more than 300, which the person doesn't really meet. So I chose to start this person on dual bronchodilators because I thought there wasn't a strong enough indication to start ICS at this point of time. So what happened? So he was started on indacaterol and tiotropium. Again, I wanted to give him something which was preferably longer acting, which was preferably once a day. I chose to give him multiple inhalers because I wanted to use an ultra LABA, and I couldn't think of a combination at that point of time whenever this was done, which had a combination that included an ultra LABA along with a LAMA, which was also once a day. So I started him on indacaterol and tiotropium in a DPI form. He saw me after 6 months. As usual, we normally ask about adherence. We normally ask whether the patient has been using it regularly, and he said yes. We reassessed the inhaler technique to make sure everything was going okay. His shortness of breath had significantly improved. His CAT score had decreased to 9, which, if you remember, was more than 20 to begin with. But he had had 2 exacerbations over the past 6 months before seeing me, neither needing hospitalization, but warranting a short course of steroids and antibiotics given to him by his family physician. So this was a cause for concern. So when we look at treatable traits, or we look at targeted therapy, we're looking at shortness of breath and we're looking at exacerbations as our 2 goals. We seem to have done well with shortness of breath, but we seem to have not relieved him of his exacerbations. He had 2 the previous year, and he had now 2 in 6 months. Chest radiographs revealed no obvious pneumonia during these exacerbations. An NT-proBNP was done during these episodes of exacerbations, which were normal, and it didn't look like there was a cardiac contribution to his breathlessness or to his exacerbations. His sputum had grown H. influenzae, which was a sensitive bug, and his tests for TB were negative. So at this stage, somebody who's on dual bronchodilators, both once a day, has come back to you. He's had 2 exacerbations. So what would be your change in the background prescription at this point of time? So let's do a poll. So the options are: you change tiotropium to glycopyrronium. So change one LABA for another and don't do anything else. Second option is you switch your LABA-LAMA in an MDI form with a spacer because you think that the person's lung function was possibly low. Maybe you didn't think that a DPI was good enough. You switch to LABA-LAMA nebulizations. You still stick to dual therapy, but you decide to switch to a nebulizer. You add ICS at this stage, or you add azithromycin prophylaxis at this stage. Shall we poll?
Yeah, I think people can vote, and here's some of the results.
Yeah, I can see it now.
You can see them? Go ahead.
Yeah, I can see it now. So some people, a good percentage of people, 42% of people thought that switching from tiotropium to glycopyrronium is a good idea. And I think it is evenly distributed in all the other 4 categories. So 14% decide to switch to an MDI form, 14% switch to a LABA-LAMA nebulizer. About 23% decide to add ICS, 15% add azithromycin prophylaxis. So I think a distribution that's all over the place suggests that this is probably a challenging case, despite the fact that we face like this every day. If you go strictly by the GOLD guidelines again, if you still believe that this is a person who had COPD to begin with and is following up with you, you look at the treatable traits that follow up. So if the dyspnea is not well controlled and the person was on a single bronchodilator, you would switch to a dual bronchodilator. In our case, the person was already on a dual bronchodilator. The dyspnea was already better. So there was no real reason to target breathlessness as a treatable trait. What our real challenge was with the exacerbations. So we know that 2 drugs which really reduce the frequency of exacerbations in the inhaled form are either LAMAs or ICS, right? The person was already on a LAMA. So if the person was just on a monotherapy of either a LABA or LAMA, you would switch to a dual bronchodilator therapy is what the guidelines suggest. But if the person's already on a LABA-LAMA combination, and the blood eosinophil at follow-up is greater than 100, right? Because at onset of treatment, you keep a higher threshold of 300. But at follow-up, if the person's frequently exacerbating, you look at a threshold of 100. That's when you would switch to triple therapy. So I think if we went by these guidelines, we would add an ICS at this stage because the baseline eosinophils were close to 200. They didn't meet the criteria for adding ICS at onset. But at follow-up with frequent exacerbations and the eosinophil count greater than 100, I would add an ICS at this stage for sure. Right? The other options in terms of frequent exacerbators, if the eosinophils were low, if they were consistently below 100, you could either add roflumilast at this stage if the person met the criteria of chronic bronchitis and a low FEV1. You could add azithromycin prophylaxis, which preferentially tends to work better in those who are former smokers. And of course, we now have dupilumab, a monoclonal antibody, which can be added if the eosinophil is consistently above 300, you're already on triple therapy and failing. Right? So if you go by this algorithm, an ICS would be the drug of choice. Now comes the challenging part. We live in an era where triple therapy is not just one triple therapy. We have a whole bunch of options that we can choose from. And that's a good thing. It's a good thing to be spoiled for choice in respiratory medicine. If you remember your practice from about 15 years ago, we had very limited options. So let's look at the different options of triple therapy. So now we've come to the conclusion that we want to use triple therapy. We have budesonide, formoterol, and glycopyrronium, which is available twice a day in a DPI format. We have budesonide, formoterol, glycopyrronium twice a day in an aerosphere format, right? So two identical drugs, both twice a day in different delivery devices. We have mometasone, indacaterol, glycopyrronium. We just had a talk in asthma where it works really well. Great advantage, of course, being that it's a once-a-day dry powder inhaler. As Dr. Chapman said, in today's day and age, I think all of us should try to put our patients on once-a-day therapy rather than twice-a-day therapy, simply because adherence tends to be so much better. And then you have a combination of fluticasone furoate, vilanterol, and umeclidinium, which is available in an Ellipta delivery device, and which is going to be very soon available in a dry powder inhaler form as well. Right? So these two, again, two identical options, different devices. Here, two identical options, different devices twice a day. And here you have an option which is once a day triple therapy. So which of these would you choose for our given patient? Let's do a poll. Okay, I think we have 100%. Okay, it's changing now. Okay, so I think the poll's closed, and it looks like a majority of those attending this webinar today would choose a combination of mometasone, indacaterol, and glycopyrronium in this situation. And there are multiple reasons to choose this, right? It's once a day. It's available as a dry powder inhaler, which is breath actuated. So the problem of coordination, the problem of using a spacer probably gets solved. Uh, I think we wouldn't want to use and I think what I tend to do with patients with COPD is that I would give them a second rescue inhaler, which in case they are short of breath at night, in case we feel the 24-hour coverage is a little challenging, we would give them a rescue inhaler to be used in addition to this. So I think this has the advantage of making sure again that the adherence to all the three drugs is maintained. And then you have the option of using rescue inhalers. So I think with this I will end my presentation. Again, the idea was not to suggest that there is one answer for everybody, but I think it's a useful thought process when you look at the different criteria based on which you're going to make your selection. Is it once a day versus twice a day? Is it a dry powder inhaler versus a different device? Is it a longer acting molecule versus a shorter acting molecule? Is it an ultra LABA versus a conventional LABA? And I think there is a lot more clarity in terms of how the longer acting inhalers, especially the once a day, tend to be associated both with better adherence and also improved efficacy in terms of breathlessness, as well as reducing the frequency of exacerbations. So thank you, and over to you, Jaideep.
Thank you very much, Lance. That was a very, very interesting case presentation. You took us through it. Maybe once we have the second case, which Dr. Murali Mohan will present, I think we can discuss a lot because there's some differences in the cases that are there. So Dr. Murali, over to you.
Thank you. Let me share my slides.
Yes, we can see them.
Yeah. So my patient is very different from the ones that you've just heard about. This is a patient with COPD and asthma. But I'm not going to be focusing so much on the inhaler of choice, but also to take you through some of the problems that we tend to have with these patients. So I bring you greetings from Narayana Health. Bangalore. So this is a patient I've been seeing for the last 2 years or more. I saw him first in September 2022 when he complained of worsening of breath, breathing difficulty since a month. He'd also had allergic rhinitis in the past, about 8 years. And he'd been seen by one of my colleagues and called ACOS, as we called it in those days, asthma COPD overlap syndrome. In October of the same year, he'd actually come to us with H1N1 pneumonia. And in the background, he had the typical comorbidities that a lot of patients with COPD have, type 2 diabetes and hypertension. But there was also a history of atopy, as I said, allergic rhinitis, and he had a family history of asthma. He was a former teacher by occupation. He had been smoking for about 10 cigarettes a day for about 10 years. Prior to his first visit, he'd quit smoking. His examination then, when I saw him in September 2022, his vitals were normal. His saturation is about 95 to 96% on room air at rest. His nose showed a deviated nasal septum and nasal mucosal pallor. He had inferior turbinate hypertrophy. On examination, he had a hyperresonant note and percussion and occasional scattered crackles. So what you'd expect from somebody with allergic rhinitis, but also asthma and COPD features in the background. So in our mind, there was very little doubt about the diagnosis. And this was his chest X-ray, and you'll agree that it's compatible with a mildly hyperinflated lung. And this was his spirometry. You can see that he has the typical scalloped pattern, a scalloped pattern that you'll see in patients with COPD. And there was a small change in his FVC, about 220 ml, 13%, but the FEV1 had not shifted at all. And this was a later trial when, again, we'd put him on treatment, and he didn't show much of a difference between the pre and the post bronchodilator. So fairly typical COPD features with some degree of improvement in his FVC. Echocardiography at that time, they've reported that he was asymptomatic, but I think they had not really bothered to take his history. They've noted a diagnosis of asthma as opposed to COPD in this patient, hypertension and diabetes. But essentially, he had fairly normal echocardiographic features. His pulmonary artery pressure was borderline. So at this point, I'm going to ask you, what is your diagnosis? Is it asthma? Is it COPD? Or is it COPD-A?
It's open for polling now.
Okay. I think people have voted very, very quickly, and I think this question really is a no-brainer. So almost 90% say this is COPD-A. 11% still think it's asthma, and I would not disagree with you. It really depends on which is the predominant diagnosis. But I think we decided to go with the diagnosis of COPD-A in this patient. And in that case, obviously, we have to make certain treatment choices. So we are through with the polling. I'll go on. I'd rather spend more time in the question answer session and listen to Dr. Chapman again. So with that diagnosis, what would be your choice of treatment? Open for polling again. Would you want to use a LABA, a LAMA, a LABA-LAMA, or a LABA-LAMA ICS, a triple combination? Can we open for polling, please?
So the audience can all poll now. Yeah, there they are.
Okay, so far we have 100% choice of triple therapy. I know this is a session on triple therapy, but so in India, this is very often what we choose. In actual practice, many people start with an ICS LABA. And soon when a person is very symptomatic, they go on to use a triple therapy these days. So that's certainly one of the choices that you can use. Right. So if our polling is done and we have a virtual 100% choice of LABA Lama ICS, he had been started by my colleague on an ICS LABA, a formoterol budesonide combination, and a fluticasone nasal spray. And I decided to continue the same because he'd experienced some improvement with it, but was still not completely happy. We continued that. And since he continued to be symptomatic, I started him on tiotropium in addition. Unfortunately, with this, he was very uncomfortable. He complained of a constant dryness of the mouth. He had a lot of urinary hesitancy, and he continued to have his nasal discharge and a very troublesome cough. This cough had features both of a postnasal drip, which was related to his nasal symptoms, his nasal problems, as well as due to his underlying obstructive airways disease. So he continued with this triple combination, and in January 2024, he developed a persistent cough, which was different from his usual cough. He also had noticed a drop in appetite and a weight loss of about 2 kilograms. His weight had previously been stable. So he had a chest X-ray done, and I'm giving you his X-ray from September 2023 on the left, and the chest X-ray from 2nd of Feb 2024 on the right. So it's about a 5-month gap between the two X-rays. And you can see the interval appearance of an opacity in the left upper zone. Not able to use my pointer, but I think it's fairly clear to everyone that there is opacity in the left upper zone, which was not present earlier. Or if you're very careful, you can see that perhaps there is the beginnings of an opacity in the left upper zone, which I'd missed completely. So what would be your next step? Would you do a CT thorax? Would you do a PET CT? Would you advise a bronchoscopy and washings? Or would you give him a course of antibiotics and review? And again, I would emphasize that there's probably no single right answer. It depends on a lot of factors: the patient's acceptance, the facilities you have at your center, what you choose to do, the discussion with the patient and his family. So can we vote, please? Can we open the polling? Okay, so as Dr. Lancelot Pinto said earlier, when you have this wider spread, you know that there's no single right answer. And I think so far, most people have chosen to go for a CT thorax. About 14% have gone for a PET CT. 11%, sorry, now it's shifted slightly. Let's give, maybe about 15 seconds more. But the top choices thus far seem to be to do a CT thorax or to give him a course of antibiotics and review. Right. So, so the antibiotics and review and bronchoscopy seem to be catching up with CT thorax. Yeah, but still the vast majority have chosen to go with the CT. This patient is not very well off. He's a retired teacher, and we know that in India, teachers don't earn a huge amount. After discussion with him, we decided to give him a course of antibiotics and review, and his cough improved. And after a month, we decided to repeat his chest X-ray. And this again is his chest X-ray. On the left, you have the 2nd of Feb, and on the right, you have the 1st of March. And you can see there's really no change in the opacity in the left upper zone. So we decided to go ahead with the CT thorax. So what would your choice be? Problem persists. This man is an ex-smoker. He had quit more than 10 years ago. He has a background history of what looks like COPD, asthma. Would you do a CT scan, a PET scan, go ahead with a bronchoscopy, or a CT-guided biopsy? We have some excellent interventional radiologists in our center. So, that's really one of the choices we often resort to. But what would you do in this case? Can we open polling, please? I think we've already opened polling. So a lot of people probably think, why didn't I do a CT scan in the first place? And that's actually a very fair comment. Maybe we should have done a CT in the first place. And we could have made out the features of the opacity earlier and decided on an earlier decision as to management. But, in this case, there were a lot of other issues, including financial issues, which is why we chose the course that we initially did. So most people seem to favor now a CT scan. More than half of them have chosen a CT scan. And about 30% have decided to go straight away with the bronchoscopy. I would probably not go for a bronchoscopy straight away. We don't know where exactly the lesion is, in which segment, and you may not see it on bronchoscopy. So I think I would completely agree with those who want to do a CT scan. So I think opting for a PET scan in the first instance is not a bad choice. And it may be argued that when you do a CT-guided biopsy, you'll be doing a CT anyway. So it may not be a bad choice to go ahead with the CT-guided biopsy. So again, problems that we face in clinical practice, and each has to be handled individually. So that was his CT, and you can see that there is an opacity in the left side. The features suggest there's speculation around, there's a pleural tag, and this was his background a little in another part of the lung. I'm not sure how well this projects, but there's also a lot of centrilobular emphysema, attesting to the fact that he doesn't have just asthma, but he has COPD and a major component of COPD. So this was the report: a well-defined soft tissue density lesion, spiculated margins, a pleural tag, central tiny cavitation in the left upper lobe, the apicoposterior segment, and it was suspicious for a neoplastic etiology. We ran it through an SPN calculator, and there's a very high suspicion for neoplasm. And as you can see, there's background small airways disease and emphysema. So we went ahead with the PET CT, and you can see that it shows a very high FTG uptake, again in the same nodule. And this was the final impression: a mildly hypermetabolic, mildly spiculated, cavitating soft tissue density nodule in the apicoposterior segment of the left upper lobe, concern for neoplasm, and they suggested a biopsy. There were no other nodes anywhere and no other hypermetabolic lesions in the rest of the body. So this was a single lesion. So what would you do? I seem to have missed out a question somewhere. So what would be your next step after doing the PET CT? Would you like to do a CT-guided biopsy? Would you like to do a radial probe EBUS, which is available in many centers? It is at ours. Would you go ahead with a segmental resection and histopathology and subsequently take further decisions about his management? Or would you do a liquid biopsy? This is a man with fairly advanced COPD. Again, it depends on the facilities in your center. So could we go to the polling, please? But, as I said, these were all options for us because we have a very good thoracic surgeon who does monoport, uniport VATS. We have an interventional pulmonology and interventional radiology team, and we have a good backup from our oncologists. So liquid biopsy is an option. So what would you vote for? Right. So far, about a little over 25% of people are voting for a CT-guided biopsy. An equal number for radial probe EBUS so far. About 50% want a segmental resection and histopathology. And I think quite rightly, there's hardly anyone opting for a liquid biopsy. Okay. So I think the numbers are fairly stable. Segmental resection and histopathology, and that's what we chose to do. We've got a good thoracic surgeon. We discussed with the family the pros and cons. We said there's a single lesion. Perhaps we can do a resection and offer you a complete cure. Very rarely do we get lung cancers at this earlier stage. And rather than go ahead with a biopsy, run the risk of, delays further, a pneumothorax, which we were not sure he'd be able to tolerate. We wanted to do it under controlled circumstances. So we went ahead and did a segmental resection. And this was the report from the pathologist. So they said this was a necrotizing granulomatous inflammation. large confluent areas of necrosis, epithelioid histiocytes, lymphocytes, and scattered Langhans type giant cells, few epithelioid granulomas. So everything suggested necrotizing granulomatous inflammation. And that was the diagnosis, a patient with left upper lobe tuberculosis. We put him on, this was the report of the surgery. I'm not going to go into that. He did very well and completed 6 months of anti-TB treatment after that. But this is probably my second last question. With reference to the tuberculoma, would you withdraw the inhaled corticosteroids and continue only with the dual bronchodilators? Would you reduce the ICS dose and continue triple therapy? Would you change from budesonide to fluticasone as the inhaled corticosteroid? Would you change from budesonide to a cyclosinide-based single inhaler triple therapy, which we actually are still able to get, though it's becoming increasingly difficult? So what would be your choice? Can we open the voting now, please? Yeah. Okay, so polling is still on. We're running neck to neck on withdrawing the ICS and reducing the ICS, but continuing triple therapy. And I'm reminded of the race commentaries on racing commentaries on radio that sometimes I'd hear. And running neck to neck are reducing the dose and withdrawing the ICS dose, but changing from budesonide to fluticasone as the ICS is also being used as an option. Okay, so a small percentage want to change from budesonide to fluticasone. I assume this will be the FF combination, the FF fluticasone rather than the FP, fluticasone furoate rather than propionate. And there are not many takers for cyclosinide. Right. So what we did is, of course, we continued with his anti-TB treatment to complete 6 months. He tolerated it very well. He had no complications. He tolerated the surgery well. That's something we were rather worried about. He continued to have episodic breathlessness and mucus secretion. Remember that he was on ICS LABA a LAMA-LABA combination and an ICS LABA and was on tiotropium. So when the single inhaler triple therapy became available of indacaterol, mometasone, and glyperidonium, we switched him to that. He promptly got better. Breathlessness is still there, but a man who was extremely breathless has now got much better control. Approximately an MMRC 2 to 3, varying a little depending on the season. And his main problem now is increased sputum production. So breathlessness he's very happy with. He doesn't complain about. His cough has largely settled. I forgot to add on this line that he continues on his intranasal steroid spray. But right now he mainly complains of increased sputum production. So last question. I chose MF because it's got very good glucocorticoid receptor binding affinity. I understand that a lot of people are worried about mometasone. It's actually a great drug to use. The two inhaled steroids with the maximum receptor binding affinity are fluticasone furoate and mometasone. The others have significantly less binding, and we know that potency is related to receptor binding affinity. And the longer it stays bound to a receptor, and the more tightly it binds to a receptor, the better the therapeutic index. And what you're seeing here is the mass median aerodynamic diameter of mometasone in a DPI is actually very good, about 3.7. And we're quite happy with this. Of course, there are extra fine particles, but they're not available in these kind of combinations except for cyclosinide. But that is really very difficult to get. So I'm actually a great fan of mometasone, and I wish we'd be using it more and more. Again, you're seeing the same receptor binding affinity very high for fluticasone furoate and mometasone. And one of the things I found is that it's not retained very long in human lung tissue, which means it's broken down. FF is retained for much longer, as is FP. And while that's seen as a benefit of fluticasone furoate, in somebody with tuberculosis, I always worry, am I leaving the drug too long locally in the lung where there is, probably still dormant bacilli? We know that even after a course of TB treatment, a small percentage of patients still have dormant TB bacilli in their lung. So sometimes, we prefer to use something that is not having too much of a local effect, which is why between FF, which is a great, inhaled steroid, I chose to go with mometasone for this patient. And remember that when you go with a dose which is low, up to 180 micrograms a day, mometasone, that is the last thing, Asthma next, 220 micrograms is a very safe dose. You don't need to give people an ICS card because it does not produce significant amounts of suppression of the HPA axis. So it's a good drug, effective, good receptor binding affinity, and is, in my opinion, extremely safe with low systemic side effects. So coming back, how would you manage the increased sputum production? Change back to tiotropium. Would you change to an inhaler, SITT with spacer instead of a dry powder inhaler? Would you add roflumilast? Now increasingly, we are going to be able to access ensifentrine. I don't think we have it yet. It's a dual PDE3, PDE4 inhibitor. So it's got bronchodilator action. And it's also got some anti-inflammatory action. So would you consider ensifentrine? I don't have any experience with it. It's only what I've read about. But let's open it for polling. Okay, so we have all choices, and I think all are very viable choices, very valid choices. But there's a significant number of people who would like to change to a single inhaler triple therapy with a spacer. That's very often my choice. But it's sometimes difficult to change somebody who's improved very nicely on a dry powder inhaler to completely change the device. Remember, this is a slightly older man. He's an educated man, but often older people have great difficulty using an inhaler with a spacer, and they dislike too many changes in the type of device. And I think Dr. Chapman also told you the same. It's not just the medication that's important, it's also the device. And I know Dr. Lancelot Pinto is a big believer in this, and he's come out with this beautiful set of QR codes, which you can use to teach your patients how to use every kind of device. So if people have not used it, please use it. I'm a great fan of that. So thank you, Lance. So options evenly spread almost throughout. About 25% want to try ensifentrine when it becomes available. 25% want to use roflumilast. Very few want to change back to tiotropium, though it's not an insignificant number, about 16.7%. And a small majority want to change to an inhaler with spacer, a single inhaler triple therapy. So I think all are valid choices. What we decided was to add roflumilast based on, I think Dr. Lancelot Pinto has already shown you this. So if a person has a lot of sputum production, despite being on a triple inhaler, his eosinophil counts are not very high. That's one choice, dupilumab. We don't have it here. You could have either gone with azithromycin, preferentially in former smokers, as this gentleman was. But since now he had a low FEV1 and he had features of chronic bronchitis, he was already a little hard of hearing. And that's a bit of a problem when you're using azithromycin long-term. We decided to go ahead with roflumilast. With that, he has had some improvement. He's tolerated it reasonably well. A lot of patients develop a lot of nausea. He didn't have that problem. He still has some sputum production, but says he is about 50% better after we started him on roflumilast. So we decided to continue with that. So I'm going to leave you with a few learning points from my patient, what I've learned. COPD with a background of history of atopy or allergic rhinitis should be managed with a triple combination, probably upfront. A change in the nature of the cough should prompt careful investigation. Remember that in India, with a high prevalence of TB, we always worry about TB. But in a former smoker, we would worry about a malignancy. A good learning point for us was not all upper lobe spiculated FDG-avid lesions in a neck smoker are malignant. In a high TB prevalence country like India, tuberculosis always can produce surprises. And that's one of the arguments for not going for the screening CTs in smokers that are used for lung cancer screening. But that's still an open question. And finally, a single inhaler triple therapy with either a LABA or ultra-LABA, a LAMA or an ultra-LAMA, and clearly we'd prefer a single dose. So ultra-LABA, ultra-LAMA seems to be favored. With an ICS, produces very good symptomatic improvement. I'll stop at this point. Thank you all and hand it back to Dr. Gogtay.
Thank you very much, Dr. Murali. Lots of learning points there. Very fascinating case that you took us through till cancer, tuberculosis, and then I think the difficult choices of what do you do when you're actually treating tuberculosis, what treatments can you continue, what do you stop, what do you switch to? So as the questions start coming in, I'm going to just start with a few general questions. So let me start with Dr. Pinto first to you that has come. You sit in Hinduja, which is a tertiary hospital. Most of the asthma patients that you see are probably already receiving an ICS LABA. In your practice, how do you really evaluate asthma control? Do you look at symptoms only, or do you actually run an asthma control test, or do you run some additional tests just to know whether the patient's asthma is controlled?
So, I mean, I think the first question is always a good clinical history in terms of, how their quality of life is. I must confess that we don't end up using formalized tests like the asthma control test as routinely as we should. And there's no real excuse for not doing that because it's an objective way. We use the CAT more frequently, but I think, it's just a matter of getting it formalized and structured. A good history followed by then, obviously checking things like adherence, checking things like inhaler technique, I think gives us a lot of information. Now, if we need additional guidance when there is confusion, sometimes things like peripheral eosinophil counts. One thing about India is that people seem to have CBCs very often. So, we don't very often need to ask for CBCs. We just need to go over the past few CBCs done for whatever reason. And very often we'll get a strong signal in terms of eosinophils, for example, which guide us in terms of whether we need to step up the ICS sometimes. We do have exhaled nitric oxide, which we have used on occasion, both to kind of cross-check on adherence as well as to make sure whether the type 2 inflammation is well controlled. But I think asthma control, just as all airway disease control, again, is divided into control of shortness of breath or controls of frequent fluctuations in case of asthma or frequent exacerbations in case of COPD. So we don't like people fluctuating a lot. And if we think adherence is in place, inhaler technique is in place, sometimes we would think in terms of escalation. And if shortness of breath is the driving force, I think dual bronchodilators instead of one and ultra LABA instead of a conventional LABA is the way to think about things.
Dr. Chapman, when you probably see patients who are referred to you, how frequently do you see asthma not under control? Let's say out of 100 patients who are treated with ICS LABA maximum doses.
Almost by definition, they are referred to me because they're not controlled. Okay. And as my case would indicate, one of the most common complaints is the enthusiasm so many of my colleagues in Canada have for twice daily maintenance therapy. And I often achieve the desired goal simply by asking patients to inhale a good maintenance therapy once daily. It's simple, it's intuitive. I don't know why these lessons are so hard to share. I must say, I was delighted that nobody this evening referred to the so-called GINA guidelines. There are no GINA guidelines. And GINA is a group of people who gather together and ponder. And for some reason, I think they've gone remarkably off the rails in their enthusiasm for treating asthma symptoms only after the patient has suffered through the symptom. And I think if we all look at modern medicine, not just pulmonary medicine, we'll realize that prevention is key. Simple maintenance therapies are key. So, yeah, most of the patients come to me uncontrolled, and for the most obvious of reasons, and it's simply remedied.
So I just want to take that further. There's been some data on possibly normalizing airflow limitation in patients with asthma. Is that possible with triple therapy? They can actually normalize. I mean, you showed roughly, or I'm not sure, 54% lung function. Do you think such a patient's lung function could potentially be normalized or near normalized with triple therapy?
I've got a couple of answers. First, with respect to triple therapy, people have looked at the characteristics that would predict the ideal patient for triple therapy. Is it the older patient? Is it the patient who has smoked? Is it the patient with some persistent airflow limitation? None of them really stand out. I would say in my practice, it is the patient who is using a bronchodilator frequently and adding that additional bronchodilator, the anticholinergic to the LABA, does produce for patients, many patients, a very useful clinical dividend. They're no longer chained to the quick relief inhaler. In terms of persistent airflow limitation, we've tossed around the term remodeling in asthma without defining it, but our concepts may change, and it may change because of some of our biologic therapies. And I'm thinking in particular of dupilumab, which produces some remarkable impact on FEV1. And I've seen patients, I thought, who had remodeled with longstanding asthma normalize their lung function on that particular biologic. So, yeah, watch this space. I think our concepts of persistent airflow limitation are changing.
Dr. Murali, you mentioned for some reason that you really like mometasone furoate as a steroid. Most people have been used to fluticasone, budesonide as the two war horses for a very, very long time. What made you consider using mometasone as a steroid, and what's been your experience in the last, let's say, 12 months or so it's been available?
So I don't think there's very much difference in terms of efficacy between mometasone and fluticasone furoate. Both are good drugs. I'm a big fan of fluticasone furoate. I'm not such a big fan of fluticasone propionate, honestly. So my go-to drug until the last year or so was budesonide. And then when the triple combination with fluticasone furoate came along and mometasone came along, it was a toss-up between the two, really. So sometimes you go with the combination that's available. So mometasone with, indacaterol and glycopyrronium seems a perfectly good combination to use. I'm not going to say I favor mometasone over fluticasone, but I kind of, switch between the two, largely depending on what the patient has been using. For example, this patient actually briefly, I'd put him on an indicaterol glycopyrronium combination before we introduced the budesonide for his care. So it just seemed obvious to go with the indicaterol glycopyrronium and mometasone combination. Again, as I said, I'm a little worried. Maybe FF is a little too potent. Maybe it has too long a dwell time within the lung. And while I'm very happy that it does not produce significant HP axis suppression, I keep wondering what it does within the lung. So this is not to rubbish FF, but sometimes you're a little more comfortable, somebody with TB, to say, look, maybe I should be using something that doesn't have such a long dwell time.
Dr. Chapman, your comments on asthma COPD overlap. We had a term ACOS in the past. We did away with the term. How frequently do you see this overlap, and is there a specific protocol that has been developed by any of the agencies to treat ACO, or just that the two diseases are existing in the same patient?
We don't have any single definition of ACO, and many of us will think of it for various reasons. A large but incomplete bronchodilator response, so elevation in nitric oxide if we measure it, an elevation in blood eosinophil count if we have such a thing. I think of the concept often in my patients, but I think we will cast the term aside in the long run. I think we will start thinking in terms of treatable traits. We will start plucking out specific pathophysiologic pathways and tailor our therapy to address those pathways. So ACO's a valuable, vague concept, I think they are out there. It's, I don't know, 15% of COPD patients, but I don't think we're going to continue to use the term in the long run.
Dr. Pinto, how would you identify asthma patients who need triple therapy? Because you actually started with COPD, but if you had to go via the asthma route, how would you identify patients who need triple therapy? Is it just that they have shortness of breath, like you mentioned, and they need a bronchodilator, or they have a low lung function and therefore they need a bronchodilator? What's your way of treating that?
I think we tend to define asthma by control, and if a conventional, again, I think once a day is always better than twice a day. I would completely agree. And MART therapy, if a person on MART therapy or SMART therapy comes up giving me the history that they've been using frequent canisters, they're not sticking to just their background dose, and therefore the need has clearly increased. The control is not good. They're not being able to achieve their targets. So at the stage where I have to make a choice between going from moderate dose ICS to high dose ICS along with a LABA, I would prefer to use a LAMA instead of moving to a high dose ICS for multiple reasons, right? I think there's a synergistic effect that clearly gives you a bigger bang for the buck. There are concerns with high dose ICS. A lot of patients on high dose ICS will come back with oral thrush. They have problems with voice, for example, becomes an issue. In the long run, I mean, we don't end up tracking our patients for things like pneumonia so well, because our patients very often don't necessarily come to us for all episodes. So I think when at that bifurcation, at that triage point, when I have to go from medium dose ICS to a higher dose ICS for poor control, that's when I would preferably use a LAMA rather than doing that. And of course, control in terms of how frequently does a person need bursts of oral corticosteroids, for example. And if I feel that's not achieving the desired control, I would switch over to triple therapy.
So,
Can I just add, when we talk about single inhaler triple therapy, I'd completely agree with both Dr. Chapman and Dr. Pinto that a single once daily treatment is the best. But there is still a small number of patients, maybe 10 to 15%, who are unhappy with a single dose, and they become symptomatic towards late night, or they just don't feel comfortable at the end of the day, partly psychological. And for that group, it sometimes helps to put them on a twice daily dose. But that's the minority. The vast majority do better with a single inhaler once daily dose and are much more adherent to that. But you've got to choose the drug, the combination, and the device according to the patient.
Yeah, I would completely agree, and I don't have a scientific basis to say this, but I think the longer you've had asthma and historically used twice a daily inhaler all your life, the more difficult it is for you to at some level accept the fact that you just take one inhaler. There's always this fear that something will happen at night. I've used twice a daily therapy all my life, and you're suddenly switching me over.
So, Dr. Chapman, if I can ask you, you have access also to all the single inhaler therapies for asthma, the fluticasone, Vilantrol, umeclidinium, or indacaterol, mometasone, glycopyrronium. I guess formoterol, budesonide, glycopyrronium is not yet approved for asthma, but the other two are. Is there a choice for you, or it doesn't really matter between the two?
There are a number of considerations. Some of them are local in terms of cost of inhalers and whether a patient has coverage. So, for example, where I practice, indacaterol, glycopyrronium, mometasone is relatively low in cost, and certainly is the lowest cost triple therapy. So I use it a great deal. What I will often do as well is ask my educator, and I'm blessed to have an educator at the end of the corridor, to review the inhalers with the patient and have the patient pick the inhaler that he or she is most comfortable with. That will guide my prescribing. But yes, it is useful to have some options, and that approach helps patients to feel part of the treatment decision.
Any comments from you, Dr. Murali? Is there a choice, or you just what comes to your mind first?
Okay. I'm actually a MDI spacer fan and have been for a long time, especially in patients with advanced COPD, not so much with asthma, but advanced COPD. But increasingly, I find that, I don't like to change the device for a patient. I like to stick to the same device. In India, we are blessed to have all kinds of devices, all kinds of combinations for these devices. So patients who can afford it, very often they go for the more expensive device. But I think it's really very difficult for the vast majority of our patients to use the umeclidinium, vilanterol, fluticasone furoate combination. So that's sometimes impossible for them to afford.
So, Dr. Chapman, we have a number of dry powder inhalers capsule-based in India, and all of them are generally similar in their deposition. So if I, for a moment, keep the device component aside, when we have all similar kind of devices which have similar deposition, why do you think that indacaterol mometasone actually had greater improvement in their lung function than high-dose salmeterol fluticasone? Is it something to do with the drugs themselves, with the potency of indacaterol as a bronchodilator? Or do you think it's just the deposition through a device and not really the pharmacology of the drugs?
I don't know if I'm being dodgy or diplomatic, but I think it's both. The breathalyzer device looks a bit old-fashioned, but it's in fact very state-of-the-art. And I think what helps in a practical way with patients is that the way it works is intuitive. So not to poke at alternative delivery systems, but when a patient inhales from, say, an Ellipta or an older discus device, they may not be sure that the dose has been delivered, but when they do it from a breathalyzer, they understand how the drug got into the device, how it got into them, and they can look at the capsule and say, well, it's all gone. It must be in me. So I find many patients do like that, but there's individual variation. You mentioned indacaterol, and I think indacaterol is our most effective, most potent LABA. And I remember presenting posters at the ERS meeting as the triple data were being shared for the first time. And many doctors pointed at the indacaterol and said, well, yeah, that's the difference maker right there. It's the indacaterol. By the way, I hope I don't get into trouble by going a little off label, but there was mention of patients who are concerned about not taking a nighttime dosage of medication. So rarely I have broken the rules, and this may not be possible in India, and again, off label here, but when indacaterol was being developed and tested initially in often elderly COPD patients, doses up to 600 micrograms per day were being evaluated, and there were no safety concerns up at that high dosage. So I'm often mindful that when a patient inhales 150 micrograms of indacaterol in the morning, say as part of a triple, if they need a nighttime dosage, I might prescribe the low dose indacaterol mometasone combination, which is available to me in Canada, and that gives the patient a total of 300 micrograms of indacaterol per day. That is well within safety margin and does take care of that nighttime need. I do it rarely, but I do it occasionally, and there may be similar options in India that I'm unfamiliar with.
Interesting. I think we probably will have similar such options coming up. But as both Dr. Pinto and Dr. Murali rightly mentioned, we have a large variety of capsule-based inhalers, which are generally transparent, which will give feedback to the patient that the dose has actually been inhaled, and we generally have same deposition. So I guess we are a little spoiled for choice. And the costs generally are not very different for most of these. And generally, I think the cost for most patients, at least in private hospitals, are affordable. Yes, in public hospitals, it's a different issue which we are dealing with, and that's something I think India as a country has to address. I'm not seeing any more burning questions, but lots of questions around triple therapy, I think, which we have answered. Any questions or any comments from you, final comments? So I don't know if Dr. Murali or Dr. Pinto has any comments for Dr. Chapman, specifically on the triple combination.
So I have a question for Dr. Chapman. When glycopyrronium is used in COPD trials, for example, it's always a twice-a-day dosing. What are your thoughts around that? Do you think the once a day or twice a day makes a difference at all, or?
I don't think that twice a day versus once a day makes a big difference clinically, and I'll point out that much of that twice a day usage or alternate dosing with glycopyrronium and anticholinergics has been forced by the FDA. There are some very strange repercussions of the primitive approach the FDA takes to respiratory medicine. And I will point out, for example, that the dosage of indacaterol available in Canada and in India is unavailable to Americans because of the FDA. So I would always hesitate to take their perspective and their guidance on just about anything respiratory.
Okay,
And
maybe too.
if current politics are any guide, it's only going to get worse, but that's another subject altogether.
Well, I think on that note, I have to thank Dr. Chapman for joining us for his talk and for answering these questions. To Dr. Pinto and Dr. Murali for their very interesting and unique cases and bringing different perspectives and a lot of learning points for everyone. Thank you to all the audience. Thank you to everyone who's been physically present at centers on this Saturday night. And I think if there is time available at different centers, they can continue discussions with their moderator while we sign off from here. So thank you all very much, and we will sign off from the webinar.
Thank you so much.
Everyone. Bye.
Thank you. Bye, good night.
Thank you.
Okay, so Sugna, we are done, I guess, right?
Yes, sir. Yes, sir.
Okay,
Yeah.
thanks.
Thank you,
Bye.
sir.